and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Braidster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. We will be taking your questions throughout the hour by phone at 1-800-452-0662, and you can email us at any time throughout the hour at phlive.ny@gmail.com. Today's program is Dental Health in New York State Children, a way to keep kids smiling. Our guests are Dr. Jayanth Kumar, the Director of the Bureau of Dental Health at the New York State Department of Health, and an Associate Professor at the School of Public Health at the University at Albany. And Bridget Walsh, a Senior Policy Analyst at the Schuyler Center for Analysis and Advocacy. Thank you both very much for being here.
Thank you.
Thank you.
So, Jay, you're here to talk to us about a way to keep kids smiling. Can you tell us, why is tooth decay considered a public health problem?
Because it affects large proportion of children, virtually almost all adults. And it affects daily living. It can affect daily living, like speaking, eating, and also it can affect school performance. So it's preventable, largely preventable, and it can be easily managed. The treatment is easier in early stages. And in spite of substantial improvement we have made over the decades or so, we still see that almost 18% of all healthcare expenditures are devoted to dental care in children. So that's one of the reasons why it's a public health problem.
Now, are there some groups where we see this problem more than others?
Yes, it's more of a problem in poorer children. And there's a national survey, and we have data from New York State, where it shows about 32% of poor children actually have oral health problems compared to only about 12% of non-poor children. So what happened over the years is tooth decay was a problem of rich in the last century, and it shifted to poor children around 1970s or so, mainly because of access to refined sugar and processed foods.
Sure.
So there are a lot of barriers for poor population, like transportation, insurance coverage is another one, and then availability of dentists in certain geographic areas. So these barriers have to be addressed by human service agencies. So dental practitioners alone cannot solve these problems, and we like to partner with human services agencies to address these issues.
Great. Now, Bridget, can you tell us more about your organization, the Schuyler Center for Analysis and Advocacy, and how did you get involved in trying to address oral health problems?
Yes, the Schuyler Center is a statewide, nonprofit, nonpartisan human services advocacy organization with a mission to improve health and human services for all New Yorkers, with an emphasis on low-income and vulnerable populations. And we've been doing this since 1872, so we have a very long history of working on these issues here in New York. We work across a wide range of domains in not only health and public health, but child welfare, early care and education, and economic security. And we became involved in the issue of children's oral health a number of years ago, probably more than 10 years ago now, when we were looking at the health factors that keep children from developing to their greatest potential, particularly in early learning and early development. And in looking at a range of factors, people started talking to us about children's oral health and that it wasn't getting a great deal of attention outside of the oral health community. So as we started to look at this and really realize the significant impact that poor oral health had on children's ability to grow, to eat, to thrive, to even smile, and to do well in school, we started advocating for policies to improve access to care and to improve prevention. So we do a lot of work not only on the policy areas in children's oral health, but we work hard to educate our colleagues and other people working with young children on the importance and the significance of oral health.
And what are some of the ways that these problems are being addressed in New York State?
I think there's two really important documents that have come out recently that will help guide oral health activities in New York State. The first is the Prevention Agenda, which is the 5-year blueprint for state and local actions to improve the health of New Yorkers, that was developed by the New York State Health Department in collaboration with over 140 organizations. And the 2013 to 2017 agenda contains several important indicators for children's oral health. Also, the second version of the New York State Oral Health Plan was released in August, and this is a specific roadmap to improve the oral health of all New Yorkers, and includes data on oral health as well as recommendations for state and local level actions that can promote prevention. And I think together that these two documents really provide a roadmap for oral health stakeholders, because it gives us benchmarks that we can aim for to improve oral health.
Now, you mentioned that the prevention agenda serves sort of as a blueprint to improve health outcomes for New York State. Can you describe the objectives and the framework within the prevention agenda that are specifically related to oral health care?
Yeah, one of the key benchmarks is to reduce the prevalence of tooth decay in children by 10%. And I think that'll be a significant decrease if we can do that over that 5-year period. We want to do that by increasing the adoption of effective prevention interventions. And these can include raising the percentage of people drinking fluoridated water and increasing the application of sealants and fluoride varnish. And Dr. Kumar mentioned earlier that socioeconomic factors are a strong determinant of oral health status. And to begin to address health disparities, there's a goal of increasing preventive dental visits by 10%.
Now, what are some of the different types of interventions that might be available that we can use to address this problem and really try to meet those objectives? Yeah,
the two different documents, the Prevention Agenda and the State Oral Health Plan, have a wide variety of interventions that can be used for that purpose. And if you look at the public health pyramid on the left here of the slide, you'll see that the factors on the bottom have the greatest influence on overall population health. And as you move up the pyramid, the interventions become more intense, but they serve fewer people. And the boxes on the right are some of the specific oral health interventions that correspond with the levels of the pyramid. And we want to start by ensuring that all children have dental insurance that covers both prevention and treatment. And we also want to increase the percentage of people in the state drinking fluoridated water. And then each level is necessary to ensure that everyone receives good oral health, but the interventions at the bottom are where we really have the greatest impact on population health.
Sure. And I would just like to remind our audience, as always, the handouts are available on our website. So if it's difficult to see the font that's on the slides, please feel free to download the slides from www.phlive.org to get a clearer picture of what we were just discussing. Now, from the national perspective, how does oral health fit within Healthy People 2020?
There are important goals. One is to eliminate disparities, and another is to improve oral health outcomes, especially the prevalence of dental diseases like tooth decay, and also periodontal or gum diseases. We call it periodontal diseases. And then to improve services like fluoridation, the use of dental sealants. It's a plastic coating placed on tooth surfaces. And also to improve dental visits.
All right. Now, pediatricians are now involved in providing preventive dental services. In a push towards improving oral health in Medicaid-eligible children in upstate New York, the Women, Infants, and Children, or WIC, SMILES program goal is to help the youngest children have healthy teeth at an early age and for families to continue good oral health practices. We had a chance to visit with Dr. Melinda Clark in Albany, New York, to learn more about this program.
So in 2011, Albany Medical Center partnered with our local WIC to bring oral health preventive services to young children. Myself or one of my partners go twice a week to the Green Street Clinic for a couple of hours, and there we meet with families of young children. We do a few things. The first is we talk about the risks for cavities for those individual children. We examine the teeth and mouth. We talk about healthy eating, healthy drinking, good importance of good oral hygiene, brushing, flossing. Finally, we help the young children who have identified to be high risk or who have dental decay to establish a dental home to get that part of their health taken care of by the subspecialist. Dental decay is the most common chronic disease of childhood, and we aren't doing as much as we can to help to prevent decay. If we can start in the mouths of very young children, then we have a chance of doing true primary prevention. So that way we can get ahead of the disease in preschoolers and then have better outcomes where the children are at elementary school, with a goal, ultimately, of trying to prevent cavities in the adult teeth or the permanent dentition. So dental exams of preschoolers in Head Starts and early Head Starts in New York State revealed that 40% of children already have dental disease, and 70% of that 41% have untreated dental decay. The earlier we can get into the mouth of young children, the quicker we can help the family and the child to make behavior change, the earlier we can get them into a dental home if they have already established disease, and the more hope that we have that we can truly prevent this disease. Fluoride varnish is a topical form of fluoride. Fluoride toothpaste would be another example of a topical fluoride. Fluoride varnish, if you apply it to the surface of a healthy tooth, can help prevent cavities from forming. And if you apply it to a tooth that already has the beginnings of tooth decay, can actually help reverse those lesions and keep it from progressing to a full cavity or a hole in the tooth that wouldn't then need a drill or restoration for a young child. We use fluoride varnish because dentists are responsible for dental health, but all of us are responsible for oral health. Pediatricians and family doctors and other health professionals that see young children are responsible for helping to prevent tooth decay. Some of the changes that we discuss are improved eating or healthier choices. We talk about changes in hygiene behavior at home, that primarily brushing and using a fluoride toothpaste. And of course, then we talk about how we can get this child into a dental home. If the child has a cavity, an actual hole in the tooth, then they need to have that filled or definitively treated by the dentist, the specialist. There are three important factors in the success of this program. The first is a willingness to embrace something that we haven't historically done. So the WIC at Green Street, Albany, recognized that their children had oral diseases, that they weren't able to get to a dentist, that the families weren't able to overcome some of these barriers to achieve dental care. The second important piece, besides willingness to do something different, is collaboration. And I was just describing that's a collaboration between Albany Medical Center and the WIC program. It's also collaboration between the health department, who's done a lot of education for primary care providers in the area, and for the WIC staff, so that the WIC staff understood the importance of this disease. And the third thing that I think is important is passion. You have to really believe that doing something different than what we've always done is going to matter. You have to believe that this disease is important enough that you're willing to do something different to make a change.
So it certainly sounds like they're doing good work and really trying to move things forward. And I know that oral health is considered a leading health indicator. Can you tell us, in New York State, is it improving? Is it improving across the country? What does the picture look like?
Well, a report came out, and it was about leading oral health indicators in Healthy People 2020, and oral health is one of them. And the report says it's getting worse. It's one of the two leading indicators that got worse over the period of years. And although overall it got worse, but we have seen improvement in children, especially improvement in preventive services. So this is related to percent of persons who visited a dentist in the last year. Mm-hmm. And we have seen in New York State a modest improvement over the years.
So that's good to see. Now, tracking oral health indicators and monitoring that progress is certainly an important thing to do. How do we measure that progress in New York State?
Yeah, it's one of the core public health functions, and the Bureau of Dental Health has been engaged in conducting surveillance activities over the last 20, 30 years. And it's part of the National Oral Health Surveillance System. So we conduct surveys of third grade children, mm-hmm. and we track certain indicators. For example, one of the indicators is caries experience. And that is related to, we look in the mouth and we see if the child has had cavities and fillings, and we count that. And also untreated cavities. So if a child had experienced cavities, whether we still see open cavities or not. And then we track dental sealants. It's a long-lasting clinical intervention. It's a plastic coating placed on teeth, and we track that one. So all these three things require examination of the mouth, and we take a random sample of schools. We, dental hygienists or dentists, go out and look in the mouth and track these things, collect it. And we also have 3 indicators related to dental insurance, fluoride tablet use, and also last dental visit. These are questions we ask of parents, and based on that, we track it. We have conducted 2 surveys over the period of about 12 years or so, and I have some data to share today.
And so, based on all of this data, how are the children in New York doing when it comes to some of these indicators?
Yeah. Over the last decade or so, we have seen some modest improvement. For example, dental caries experience decline, or the prevalence of tooth decay declined by about 9 percentage points. And also untreated cavities, that percent also declined. And we have also seen improvement in sealant prevalence, that is the receipt of sealants. So overall, we have seen modest improvement. It's about 1% a decrease per year.
Okay.
And with respect to most of the chronic diseases, especially like tooth decay, it's considered significant.
Well, that's good to hear. Now, do we see any discrepancy with these improvements when it comes to high and low income populations?
Yes, as I said earlier, tooth decay is a problem of, more of a problem in poor children these days. So in our survey, we saw a discrepancy or disparity between lower and higher income children. Here, lower income children refer to those children who are on free and reduced lunch program. All the others are categorized as higher income in our survey. So as you can see, our target is by 2017, no more than 41.5% of children should have cavities. And what we see is a big disparity between lower and higher income. In order to achieve this target, we have to make significant improvement in overall caries experience in lower income children.
So we see there from that chart that lower income have greater rates of suffering from dental or oral disease. Do they receive dental care?
We have tracked that indicator also. And we have seen, although we have seen modest improvement, we still see a big disparity between higher and lower income, again, in the receipt of treatment, and also in the receipt of preventive services. For example, with respect to untreated caries, we have to make significant improvement among lower income children. And it's same with the use of dental sealants. So we have to increase from 36% to about 50%.
And so what are some of the oral health indicators that we're currently tracking in New York State?
In addition to these 3 clinical indicators, we have looked at dental insurance coverage because it's an important determinant of dental visits.
Absolutely.
And we have also looked at fluoride tablet use. Fluoride tablets are prescribed in areas where drinking water is deficient in fluoride.
Okay.
And also we track last dental visit within 1 year. And we have seen improvement with respect to all these 3 indicators. So more children are covered by dental insurance, more children have access to fluoride, and more children are visiting dentists. So overall, good news.
Well, it's good to hear that overall the picture is looking a little bit better. Now, there are groups where we haven't seen as much of an improvement. Can you explain what might contribute to the lack of improvement for those groups?
So we also analyze data by geographic regions. For example, New York City and rest of New York. Interestingly, lower income children in New York City have done better compared to lower income children in upstate New York or rest of New York.
That is interesting.
Yeah, there is almost a 20 percentage point difference between these two groups. So when there are differences like this, we start exploring and formulating hypotheses why there is so much of a difference. For one, New York City children have access to fluoride through drinking water, whereas in the rest of New York, access to fluoride in drinking water is far less. Only about less than 50% of children receive it through drinking water.
Okay.
So that's one. And if they're on fluoride tablets, compliance is a big issue. They have to take fluoride tablets every day, and that's difficult for a lot of families.
Absolutely.
So there are other reasons. Could be regular dental visits. There wasn't much of a difference between rest of New York and New York City children with respect to dental visit rates. So then we started, we wanted to explore if sugar-sweetened beverage consumption, is there a big difference between rest of New York and New York City children? So we had a question, and we asked about soda consumption, and another question about other sugar-sweetened beverages. So the analysis shows that there is a difference between New York City children and rest of New York in terms of soda consumption. More children in New York receive fluoride through drinking water, and also fewer children drink sugar-sweetened beverages, particularly soda consumption, far less consumption of soda.
That's interesting data. That actually surprises me a little bit, but good to know to help, in planning interventions and moving forward with this problem.
Yes.
Now, what role do dental practitioners have in addressing the high consumption rates of sugar-sweetened beverages?
So dental offices can play an important role in addressing common risk factors. As you know, sugar-sweetened beverage is a risk factor for obesity, diabetes, and so many other health problems. So dental offices can play a major role in educating and counseling patients about sugar consumption, because sugar is one of the risk factors for tooth decay. And the way tooth decay occurs is because of the interaction of bacteria on carbohydrates like sugars, and the acid generated demineralizes tooth. So addressing sugar consumption is an important part of dental practice, in my opinion. We have recently made some changes in the Medicaid program to reimburse dental practitioner for tobacco cessation counseling. So these are common risk factors for overall health that can be addressed in dental offices very effectively.
Great. Now, can you go into more detail and describe some of the oral health problems that young children experience?
Yeah. We have traditionally focused on school-age children. So in about 15 years ago, we used to say, take your child to dentist at age 3.
Okay.
So that changed, that recommendation changed. And now we say, take your child as soon as the first tooth erupts, or by age 1. So it's primarily because when tooth decay occurs in young children, especially when there are a lot of cavities, it's very difficult to treat in dental chair, very difficult to get cooperation for very young children. These are children under the age of 6. So many children are taken to hospital operating room for treatment of cavities. About 4,800 children are treated in operating rooms in New York State, most of them under general anesthesia. So it's very expensive.
Yeah.
It costs about $5,000 per child to treat in the operating room. And very few children actually receive preventive services, especially those under the age of 3.
I mean, that's a pretty surprising, at least to me, a surprisingly high number of children that are being seen in a hospital for dental care. How frequently does this actually happen?
As I said, about 4,800 children are taken to operating room every year. And more children also go to emergency rooms with dental problems. So we've been tracking these indicators. So this is one of the indicators where we haven't seen improvement at all. Actually, it went in the opposite direction. We wanted to reduce emergency department and ambulatory surgery facility visits from 2,900 to about 1,500 over the last decade. Instead of that, it actually doubled. Wow. So this is an ambulatory sensitive condition, and we should be able to prevent this.
Okay. Well, the Health Foundation for Western and Central New York is committed to improving the health and health care of the people in their communities. In response to this clear and urgent need to improve the dental health of young children living in poverty, they launched the Chompers, bringing dental care to kids in 2010. We had a chance to visit Kara Williams to find out more about this program.
The Health Foundation for Western and Central New York is a private foundation. We serve 16 counties in upstate New York. Dental disease can have a huge impact on children under the age of 5, especially those who are living in communities of poverty or in families in poverty. Our children's oral health work is a great fit for our overall approach and priority in the community. Kids' oral health is an issue that is both entirely preventable and has a huge impact on children in poverty. And historically, it's not a place where a lot of other funders have spent a lot of time and attention, at least in our communities. So for us, it was a natural fit to want to get involved because we could make a huge difference. Dental disease is one of those silent epidemics. It is something that it tends to not be on most people's minds. And in families that are impacted by poverty, there are so many other urgent problems that those families are facing, so many barriers, that oral health tends to not be on the high list of priorities. Often getting good oral health for their kids is not something they either understand is a high priority or can fit into their lifestyle. And sadly, for kids who are struggling with poor oral health, it can impact their ability to learn, they're in pain, they're distracted, it makes it harder to eat, which leads to poor nutrition, and it can have a variety of long-lasting negative impact. The Health Foundation designed an oral health program called Chompers, Bringing Care to Kids, a number of years ago. What was important to us at the foundation was that we were providing both education and screening and treatment to children in the community where they already go. The education piece is called Cavity-Free Kids. It's a preschool curriculum out of Washington State. A second component is called Portable Dental Care. We have trained dental clinics across our communities to use portable dental equipment. And the third part of Chompers is called fluoride varnish. And that's something that pediatricians can do. Many families understand and prioritize pediatric visits. And so we wanted to know, is there a way that pediatricians and other primary care providers could be involved in helping with oral health? The Health Foundation's Chompers program uses a variety of partners. Because we're doing education and screening and treatment in a variety of different settings, we had to have a wide range of partners. We're working with Head Starts and universal pre-Ks and WIC offices and community centers. We're also partnering with, in New York State, Article 28 dental clinics and hospitals and federally qualified health centers and pediatric offices, and a number of just community champions who believe very strongly that kids' oral health is an important issue. One of the interesting things that happened, because we're a foundation, we issued a request for proposals and invited different partners to apply to be a part of the program. So in some communities where we have Chompers, they might only have the education, the Cavity-Free Kids curriculum. Other communities had only portable dental. And then a few communities had both. So we were able to see with our evaluation what the impact was. And we found significantly, drastically improved outcomes when you had both elements. If you could educate the children and their families and their providers about oral health and how important it is, and you can provide good oral health care where they are in the community, you can have a huge impact in improving that oral health. The Health Foundation has been so pleased with the incredible impact the Chompers program has had in the community that we are already expanding it. We started off 2 years ago with this program, having 6 organizations doing Cavity-Free Kids, the education for preschoolers, and we had 4 organizations doing portable dental care. And now we are expanding that number significantly. We're reaching out to more communities and more sites, trying to get more people engaged in oral health education and screening and treatment overall, and with the Chompers program in particular.
So there seems to be a lot happening around New York State, and there's a lot of options for oral health prevention. What does New York State recommend?
When we recommend interventions, especially at the community level, we look for guidance from expert panels. There are actually 2 expert panels One is called a Guide to Community Preventive Services. The other one is called Guide to Clinical Preventive Services. So one of the recommendations by the expert panel is to promote fluoridation, that is the addition of fluoride to drinking water. Actually, fluoridation started in New York in 1945, so we have a rich history. We have extensively studied the benefits of fluoridation as well as the risks associated, if any, with fluoridation. So we want to increase the percent of the population in New York State on public water supplies from the current level of about 71.4 to 78.5. That's the target in the prevention agenda. So there are communities that can benefit from this. And as this map shows, there are some communities, they're all colored red. That means those counties are not receiving the benefits of fluoridated water. So we have about 123 systems that are currently fluoridating, and we want to improve the quality of fluoridation program, and also we want to expand the extent of fluoridation in New York State. We have a lot of resources available for communities if they're interested in implementing fluoridation and also improving the quality of fluoridation program.
So that certainly seems like a really good option for reaching lots of people. Can you tell us more about school-based dental programs as another option?
Right. That's another preventive service recommended by the Guide to Community Preventive Services. School-based programs are very effective in reaching large number of children, especially long-lasting intervention, the dental sealants that I talked about. Mm-hmm. We can target specific schools where it's very difficult to receive services, not enough dentists practicing in the area, or they have other barriers. We can target those schools. Usually Centers for Disease Control recommends that we should target those schools that are in areas where the percent of the population of children participating in the free and reduced lunch is about 50% or greater. So we have about 1,000 schools participating. We have 56 providers. These are federally qualified health centers, local health departments, or hospital-based public health programs that go to schools using portable equipment or mobile vans. So they can go to schools, see children, and provide these clinical services. That's not the only way where we can improve dental visits and clinical preventive services. Mm-hmm. For example, there is a law now requiring schools to distribute dental certificates along with medical certificates in certain grades. So schools can encourage parents to take their children to dentists, mm-hmm. link them to a source of care, and encourage dental visits and thereby clinical preventive services.
That sounds like an excellent idea. Now, how often should children really have dental visits to prevent oral health issues such as caries?
Yeah, we usually track annual dental visits. Okay. We have tracked it in our state Medicaid program, for example, over the years, annual dental visit by age. And what we observe is overall, less than 40% of children visit a dentist in the Medicaid program. And as this slide shows, the utilization of dental services in younger children, particularly those below the age of 3, is very low. So that's where we can make a significant impact by improving dental utilization in younger children, as well as overall improvement.
Now, so we know that oral health issues are a real public health issue. How can we bring about changes at the community level, which we talked earlier when we looked at that pyramid, doing community level changes certainly has a greater impact than at the individual level?
In talking to our partners and stakeholders, many of them suggested that we should be focusing on younger children, and we should provide tools for communities to engage and to assess what are some of the best interventions. So there is a paper published from Colorado. Researchers looked at various interventions using a computer simulation technique. So based on costs, how much money is needed to invest, and the return on investment, how many cavities can be prevented. So these computer simulation models can inform communities about various interventions and what are the relative payback on different interventions. So what we did was we engaged several experts, Dr. Burton Edelstein at Columbia University, along with an expert in computer simulation models, Gary Hirsch, and with support from his team at Children's Dental Health Project in Washington, D.C., and with support from the two foundations in New York State, the New York State Health Foundation and also Community Health Foundation in Western and Central New York, along with SCAA. And several other people, we got together and decided what interventions should be modeled in a simulation. So we applied this computer simulation model to New York State Medicaid population, and we looked at various combinations, and we refined the Colorado model. We added a couple of other interventions, and we have some results to share about the model. So this is a tool that can be used to inform communities about various interventions and how it can be implemented, and also what will be the return on that investment.
So let's talk about that. What are there cost benefits or savings when it comes to implementing any of these specific interventions? So
we actually looked at about 9 different scenarios. And I'm going to talk about only 3 to make it simple. And the first one is community water fluoridation. So over the 10 years in young children, if you invest $1, the return appears to be around $10. And we can also promote toothbrushing. So community water fluoridation is a community level intervention. Communities can make the decision, promote it, implement it. Whereas toothbrushing is an individual level intervention. So at home, they can improve self-care. Parents can supervise children and encourage toothbrushing. And that is, for every $1, the relative payback is about $1.40. And again, intensive preventive visits. That is encouraging children to be seen in dental offices and also in pediatricians' offices, and encouraging them about healthy habits, encouraging toothbrushing. Those kinds of interventions also show return on investment. So I want to say that this is a relative payback. This is not, we didn't figure in all the cost savings associated. For example, transportation costs, time lost, productivity lost. In a typical economic evaluation, we include all those expenses, but we didn't do this. This is mainly treatment costs and the cost of implementation of the program. So this is something we can discuss with communities interested in implementing various interventions.
And those are certainly promising numbers. Now, Bridget, can you talk about how your organization promotes evidence-based interventions?
Yes. Last year, the Scholar Center embarked on a 3-year project to reduce dental disease in children and help the state achieve the goals of the prevention agenda. And to do that, we have 2 different components. One is looking at state-level policies that promote prevention, and the other is engaging communities around disease prevention. So at the state level, what we're looking at are policies across that pyramid we saw earlier. So we're looking at prevention activities, everything from ensuring that all children have dental insurance to increasing the number of people drinking fluoridated water. We're even looking at things like, are we using the right indicators to measure oral health in New York State? And we're exploring avenues to help communities develop local partnership to encourage local level actions on disease prevention.
So that's something that I think is very important, the idea that we really have to engage a variety of community partners to make things happen. So can you talk about that process, about how you manage to engage different partners?
Yeah. Our community work is starting with the early childhood caries simulation model that Dr. Kumar just discussed. And oftentimes when you find great research like this, it doesn't get used. It gets put on a shelf and that's the end of it. We're actually using that research as the foundation for the development of a replicable program for community engagement to actually reduce ECC in communities. And it's a pretty exciting effort because we're actually creating a program that different communities can use over time and to see a measurable decrease in early childhood caries. And we're initially working in 2 communities. We started this in Jefferson County earlier this year, and we just began a program in Buffalo. And we're assisting to creating of local level leadership teams. And these are teams of not just oral health professionals and health professionals, but really the wide range of providers that you heard Dr. Clark and Carol Williams discuss in their interviews, and that Dr. Kumar talked about. So we really need to engage WIC providers, early care and education, Head Start, just anybody that really works and sees children and families. And so we've been successful in getting wide variety of providers and community partners at these local leadership teams. And then we're using a community campaign kit that's been developed for this work to help them choose the strategies that they feel will work more successfully in their community based on their need and based on what's already existing in their community. And then they'll begin implementation of those strategies. And these are all strategies that are taken directly from that simulation model. And then we're going to be providing continuing technical assistance and working to refine this campaign toolkit so that it can be used for future communities.
Well, it certainly sounds very comprehensive and like you've laid the groundwork for this to be very successful. Can you talk about the process you used or how you started to roll out this project?
Yeah, so we started, like I said, with that simulation model, and we started to think of what those interventions were and then how can we think about implementing them in a community. So we've designed a program that will provide communities with 2 intensive workshops on how to use the model to select the strategies for their community, and then providing them with training on communication and campaign development around early childhood caries. We know that for a lot of people this is a new topic, a new issue. Even people that work with young children may not understand the significance of oral disease, particularly in primary teeth. So there's a large educational component to the community and to bring in more partners and to leverage more resources in the community. So the communications on early childhood caries in the community is an important part of this program. And then we'll help with ongoing technical assistance on implementation. And I think what's really exciting about this model is that we're not trying to create new programs. What we're trying to do, let's say for example, a community wanted to increase the number of children receiving fluoride varnish or the rate of children in their community who were toothbrushing on a regular basis, because toothbrushing was one of the important strategies. What we'll be trying to do is to take best practices and replicable evidence-based models and programs that are already existing in other communities and bring them in so a community can take 3 or 4 very targeted, specific programs, get the entire community involved in the reduction of early childhood caries and understanding what this could mean for the health of their children, and then measure a reduction in this disease over time in that community. So it's a real, it's an intervention or a program that really focuses these interventions in a real targeted way in a community.
Which sounds terrific. Now, who were some of your partners in making this happen?
Yeah, well, this project is really a great example of what Dr. Kumar talked about earlier in terms of needing to develop partnerships. So in addition to the local partnerships that we're creating, we've really engaged a terrific team to help develop this at the state level. Both the Children's Dental Health Project and the State Health Department were instrumental in developing the simulation model that we're using, and they're both engaged in our work going forward. The Children's Dental Health Project has developed the community campaign kit that we're using and providing workshops, the training on communications, technical assistance, connections to best practices. The health department's been providing us with data and scientific evidence and also information on best practices and replicable models that we can use. The project's being funded by the New York State Health Foundation and the Health Foundation for Western and Central New York, and they've also been great partners in terms of thinking about how to implement a program on a community basis. So they've been very involved in the process as well. And then one of our other partners is the Oral Health Center of Excellence, and they've provided a lot of assistance in terms of data and data collection and data analysis in these communities. They're helping to identify best practices. They're going to be developing a library of best practices that all communities can then go and try to see which of these models might fit best in their community based on the strategies they want to impact, and then providing ongoing technical assistance. And so what we're really excited about is that after all this work in these communities and with the assistance of all these partners, we're going to have a model that other programs can then come and take and say, how do we do this in our community to reduce early childhood caries? How do we make our community partners and the people that we work with more engaged and interested and on the long-term impact this is going to have on the health of the children and their ability to learn once they get to pre-K and kindergarten, and then just their overall health and development going forward. So it's a pretty exciting project in that it does have a lot of community engagement, a lot of community support.
Great. Now, Jay, can you tell us more about the Oral Health Center of Excellence?
Yes, the State Health Department provided funding to Regional Primary Care Network in Rochester to establish this Oral Health Center for Excellence. There are several components. One of the key components is oral health surveillance. It's important to establish targets and also to track it. So the Center for Excellence has the capacity to assist communities in tracking some of these indicators. Also, community water fluoridation. They can provide technical assistance as well as put together resources and answer questions related to community water fluoridation. They also provide training to water system operators or others who are interested in promoting water fluoridation. Then there are interventions that schools can undertake, so they can provide technical assistance about school-based. So they act as resource center and provide consultations to communities interested in promoting oral health. So one of the interesting things about early childhood caries, in the past we have always talked about reducing tooth decay, but here we have an opportunity to eliminate cavities, especially in 3-year-olds. So we want to change the social norm of accepting cavities as an inevitable outcome to not accepting cavities. So it's exciting that the work that SCAA is doing in communities presents an opportunity to create a generation of cavity-free children.
Which would be excellent. Now, can you briefly tell us about some of the initiatives that communities are undertaking?
Yes, we received a grant from Health Services Administration to promote oral health during pregnancy. And this is to integrate community-based strategies into existing programs. The State Health Department has funded 22 projects. They're called maternal infant community health collaborative projects throughout New York State. We want to work with Monroe County Perinatal Network and with assistance from Oral Health Center of Excellence. And we want to develop a best practice model because we want to, pregnancy is an opportune time to educate parents and also to prevent early childhood caries, because the way cavity-causing germs are transmitted, they're from mostly caregivers to infants, and also inappropriate feeding habits.
Okay.
Like, babies are fed with bottles containing a lot of sugars. So some of the risk factors can be modified, and their oral health can be improved. So we want to target pregnant women and improve their oral health so that their children's oral health will be improved. So we'll be working with Monroe County Perinatal Network, and this is part of a national learning collaborative. So we will be sharing our experience with not only projects here in New York State, but also with projects in other states. It's going to be a national initiative, and HRSA has this vision to reduce dental caries in children and promoting oral health during pregnancy.
And is technology playing a role in addressing this problem?
Yes, we have a project in New York City. Researchers at Columbia University received a grant from Center for Medicaid and Medicaid Innovative Services. And it's an iPad application for assessing risk, which could be used for education and counseling, as well as set goals and plan action. They will be working with many hospitals in New York City. The interesting part is this model utilizes community health workers to educate and also to address some of the risk factors. And it encourages non-surgical treatment.
Great.
So surgical treatment is, treating cavities by filling, cutting the teeth, and operating rooms. So this is to initiate non-surgical treatment very early. And some studies show that cavities, before cavities occur, there is a phase, and during demineralization phase, during that time, intervention can be implemented and reversed. So it's an exciting project, and we are very interested in testing, seeing the results of this study being done at Columbia University.
Great. Now, is there any, I've heard about telehealth in a variety of different medical fields. Is there anything similar in dentistry?
Yes, there are telehealth projects, and especially one at Finger Lakes. They started very early. Finger Lakes Community Health Teledentistry Project is being implemented in collaboration with Eastman Institute of Oral Health. The project is called the Vibrant Teledentistry Project. The providers, like dental practitioners in Finger Lakes, can communicate with pediatric dentists at Eastman Institute for Oral Health using teleconferencing technology. So they can communicate, they can assess risks, they can figure out whether these children can be managed in dental offices or they have to be treated in an operating room. So usually the waiting time for operating room is about 4 months. I've heard about 4 months of waiting time for operating room. So, and what it does is it eliminates the need to travel multiple times, especially from rural areas. So this is very helpful, and there are other projects in the rest of the country, but Finger Lakes Community Health Center has demonstrated the utility of this technology.
Great. Now, I want to make sure we have time to get to questions, so I'll just ask you quickly. You've shared a lot of information. Are there key messages you'd like to share with our audience as a take-home?
Yeah, as we saw, we are trying to integrate oral health into health policies and programs to prevent tooth decay. And also, we want to establish targets that we have done already, and we want to track progress with respect to these targets. And we want to support evidence-based interventions, and we want to share experiences. And most importantly, we have to build partnerships and leverage resources to promote oral health.
Yeah, and on that last one on building partnerships, I think that one of the things that we hear at the Schuyler Center a lot, because we don't, we deal with a lot of organizations that work with children, is that people recognize sometimes that the children they're working with have oral health problems, but they're not sure what to do about it, and they didn't even know it was preventable. And so any sort of partnerships where we can connect people in communities with early childhood providers and people working with young children so that they can figure out and work together to reduce disease in children. I think those partnerships, so we're looking beyond the traditional people that are usually working in oral health, are going to be really critical to changing that mindset that, that early childhood caries and dental disease in children is acceptable. And so I think that that's really an important takeaway, is to look for those partnerships.
Absolutely, that makes sense to me. Now we have a few questions from the audience. We'll see how many we can get through. The first is, we have other mechanisms for delivering fluoride to children, such as fluoridated toothpaste and rinse. Why is community water fluoridation still necessary?
So when we add fluoride to drinking water, it reaches the whole population. So it's a passive intervention. There is no need for an individual to take active action other than just drink tap water.
Okay.
So with respect to other interventions like fluoride tablets, toothbrushing, so children have to engage in that activity on a regular basis. And that's where the problem is. The compliance becomes an issue. So when compliance is not great, the effectiveness goes down dramatically. So although clinical trials show good results, when it's implemented at the community level and the participation is lower, the overall impact at the population level will not be that great. Whereas with fluoridation, it reaches everyone regardless of socioeconomic status.
Sure. Now another question, how do I start a school-based dental program? What are the steps, and are there resources out there?
So the first thing is to identify the need in the community and figure out what schools can be targeted for such an intervention, and assess whether dental care is available in the community or not. So, and then, put together a partnership, and especially in partnership with the schools, they will be able to figure out what the cost will be and also the impact will be. And then reach out to the state health department, because we have guidance document. We approve these projects. So in order to get the resources, there are many resources available. We have listed some at the end of the presentation. They can reach out to those resources, and also reach out to the Oral Health Center for Excellence for guidance.
All right. I have a question. I am the public health dental hygienist living in a town where they took fluoride out of our city's water. We're considering trying to restart the fluoride swish program back in our schools. Do you have any thoughts on this?
Yeah, fluoride rinse program is another strategy implemented in schools. If a school is located in a non-fluoridated area, it looks like this is a school that is in a non-fluoridated area. And also, if they don't have any other source of fluoride, like tablets, access to tablets, and is not that frequent, then this is a worthwhile program to implement in schools.
Okay. Well, thank you both very much for all the information that you've shared. We are out of time for questions today. I'd like to remind everyone that's watching, on the handouts, there are a list of resources available that you can refer to as well. So thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming webcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. This webcast will be available on demand on our website within 2 weeks of today's show. Please join us for our next webcast on November 20th, Crossroads, the Built Environment, Health, and the New York State Prevention Agenda. I'm Rachel Breidster. Thanks for joining us on Public Health Live.
The 2% of poor children actually have oral health problems compared to only about 12% of non-poor children. So what happened over the years is tooth decay was a problem of rich in the last century, and it shifted to poor children around 1970s or so, mainly because of access to refined sugar and processed foods.
Sure.
So there are a lot of barriers for poor population, like transportation, insurance coverage is another one, and then availability of dentists in certain geographic areas. So these barriers have to be addressed by human service agencies. So dental practitioners alone cannot solve these problems, and we like to partner with human services agencies to address these issues.
Great. Now, Bridget, can you tell us more about your organization, the Schuyler Center for Analysis and Advocacy, and how did you get involved in trying to address oral health problems?
Yes, the Schuyler Center is a statewide, nonprofit, nonpartisan human services advocacy organization with a mission to improve health and human services for all New Yorkers, with an emphasis on low-income and vulnerable populations. And we've been doing this since 1872, so we have a very long history of working on these issues here in New York. We work across a wide range of domains in not only health and public health, but Child 2013 to 2017 agenda contains several important indicators for children's oral health. Also, the second version of the New York State Oral Health Plan was released in August, and this is a specific roadmap to improve the oral health of all New Yorkers, and includes data on oral health as well as recommendations for state and local level actions that can promote prevention. And I think together that these two documents really provide a roadmap for oral health stakeholders because it gives us benchmarks that we can aim for to improve oral health.
Now, you mentioned that the prevention agenda serves sort of as a blueprint to improve health outcomes for New York State. Can you describe the objectives and the framework within the prevention agenda that are specifically related to oral health care?
Yeah, one of the key benchmarks is to reduce the prevalence of tooth decay in children by 10%. And I think that'll be a significant decrease if we can do that over that 5-year period. We want to do that by increasing the adoption of effective prevention interventions. And these can include raising the percentage of people drinking fluoridated water and increasing the application of sealants and fluoride varnish. And Dr. Kumar mentioned earlier that socioeconomic factors are a strong determinant of oral health status. And to begin to address health disparities, there's a goal of increasing preventive dental visits by 10%.
Now, what are some of the different types of
child welfare, early care and education, and economic security? And we became involved in the issue of children's oral health a number of years ago, probably more than 10 years ago now, when we were looking at the health factors that keep children from developing to their greatest potential, particularly in early learning and early development. And in looking at a range of factors, people started talking to us about children's oral health and that it wasn't getting a great deal of attention outside of the oral health community. So as we started to look at this and really realize the significant impact that poor oral health had on children's ability to grow, to eat, to thrive, to even smile, and to do well in school, we started advocating for policies to improve access to care and to improve prevention. So we do a lot of work not only on the policy areas in children's oral health, but we work hard to educate our colleagues and other people working with young children on the importance and the significance of oral health.
And what are some of the ways that these problems are being addressed in New York State?
I think there's two really important documents that have come out recently that will help guide oral health activities in New York State. The first is the Prevention Agenda, which is the 5-year blueprint for state and local actions to improve the health of New Yorkers that was developed by the New York State Health Department in collaboration with over 140 organizations. And the 20
children, a way to keep kids smiling. Our guests are Dr. Jayanth Kumar, the Director of the Bureau of Dental Health at the New York State Department of Health, and an Associate Professor at the School of Public Health at the University at Albany. And Bridget Walsh, a Senior Policy Analyst at the Schuyler Center for Analysis and Advocacy. Thank you both very much for being here.
Thank you.
Thank you.
So, Jay, you're here to talk to us about a way to keep kids smiling. Can you tell us, why is tooth decay considered a public health problem?
Because it affects large proportion of children, virtually almost all adults. And it affects daily living. It can affect daily living, like speaking, eating, and also it can affect school performance. So it's preventable, largely preventable, and it can be easily managed. The treatment is easier in early stages. And in spite of substantial improvement we have made over the decades or so, we still see that almost 18% of all healthcare expenditures are devoted to dental care in children. So that's one of the reasons why it's a public health problem.
Now, are there some groups where we see this problem more than others?
Yes, it's more of a problem in poorer children. And there's a national survey, and we have data from New York State, where it shows about 30.
Hello, and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Bradester, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. We will be taking your questions throughout the hour by phone at 1-800-452-0662, and you can email us at any time throughout the hour at phlive.ny@gmail.com. Today's program is Dental Health in New York State.